Something is happening inside clinics and hospitals across this country that most patients over 70 are never told about. A growing body of medical research, published in some of the world's most respected journals, has found that certain routine health tests that millions of seniors are still being scheduled for year after year without question, may be causing more harm than good after the age of 70. We're not talking about fringe theories or internet health forums. We're talking about major medical reviews involving hundreds of thousands of older adults, shifting clinical guidelines from respected health panels, and a quiet but urgent conversation that's happening between researchers. A conversation your doctor may not have time to bring to your appointment. Today, we are breaking down 6 health tests that medical experts now say deserve serious scrutiny for adults over 70. Not to tell you to stop anything, but to arm you with exactly the questions that could protect your health, your quality of life, and in some cases, your life itself. And the number 1 test on this list, it is one of the most commonly recommended procedures in all of senior healthcare. Millions of adults over 70 have it scheduled right now. And the latest research strongly suggests that for many of them, the risk of going through with it may far exceed any benefit. Stay with us. We'll get there. By the end of this video, you'll know which tests carry documented risks that increasingly outweigh the benefits after age 70, what specific questions to bring to your next medical appointment, and how to have an informed, confident conversation with your doctor so you are driving your healthcare, not just following a schedule that was set up when you were 50. We're counting down from 6 to 1. Each item gets more important, and number 1 will surprise a lot of people who thought they were doing everything right. Before we get into the list, drop a comment right now. Tell us your age and where in the world you're watching from. We genuinely read every single comment, and knowing who's in our community helps us make sure these videos speak directly to your experience. We'll see you down in the comments. Now, let's get into it. Test number 6, annual full-body CT scans. We're starting with a test that has been heavily marketed directly at seniors as a kind of premium peace of mind wellness service. The annual full-body CT scan. On walk-in imaging centers have advertised these scans for years. The pitch is seductive. Catch cancer early. See exactly what's going on inside your body. Stay one step ahead of disease. And on the surface, who wouldn't want that? Here's what that marketing consistently fails to disclose. A full-body CT scan exposes a person to ionizing radiation at levels significantly higher than a standard chest X-ray. Depending on the protocol used, a single full-body scan can deliver radiation equivalent to several hundred chest X-rays in one session. Medical experts agree that ionizing radiation accumulates in the body over time, and for adults over 70, whose cellular repair mechanisms are naturally less efficient than they were at younger ages. This exposure carries a real and measurable cancer risk of its own. But the radiation issue is only half the concern. There's also what researchers call the incidentaloma problem, and it is where many seniors suffer the most harm they never saw coming. A large-scale analysis published in a leading radiology journal found that full-body CT scans in asymptomatic adults, people with no symptoms at all, detected incidental findings in the vast majority of patients. That sounds like a good thing. It isn't. The overwhelming majority of those findings turned out to be benign, harmless cysts, minor variations, age-related changes that posed zero threat to health or life. But once detected, each finding set off a cascade: follow-up imaging, specialist referrals, needle biopsies, and in some cases, unnecessary surgeries. This is the cascade of harm that medical researchers have documented extensively. Now, one scan leads to another test, which leads to an invasive procedure, which carries its own serious complication risks, all to investigate something that was never going to hurt anyone. A recent review involving thousands of older adults found that the psychological toll of incidental findings alone, the anxiety, the disrupted sleep, the weeks of uncertainty while waiting for results, had measurable negative effects on quality of life, even when every single finding turned out to be nothing. What to discuss with your doctor. Ask whether there is a specific, symptom-driven clinical reason you need a full-body scan. Ask about the radiation exposure risk relative to your age and health profile. And ask what the management plan would be if something incidental shows up. Test number 5. Routine. Annual thyroid screening in asymptomatic adults. Thyroid testing has become almost reflexive in primary care. A TSH blood test, thyroid-stimulating hormone, is frequently included in the routine annual lab panel for seniors, regardless of whether they have any symptoms that would suggest a thyroid problem. For patients who have symptoms, fatigue, unexplained weight changes, cold sensitivity, or a personal or family history of thyroid disease, regular monitoring makes clear clinical sense. But for asymptomatic older adults, the evidence has shifted in ways that many patients simply aren't hearing about. A landmark study published in the New England Journal of Medicine followed over 700 older adults diagnosed with subclinical hypothyroidism, meaning their TSH levels were mildly elevated, but they had no symptoms. The researchers found that thyroid hormone treatment produced no meaningful improvement in symptoms, energy levels, or quality of life compared to patients who received a placebo. None. The treatment made no measurable difference. This finding matters enormously because when routine screening detects a mildly elevated TSH in an older adult, the clinical pathway almost always leads toward treatment. And that treatment, most commonly levothyroxine, is not without consequences for seniors. Documented side effects in older adults include increased heart rate and palpitations, accelerated bone density loss, and a significantly elevated risk of atrial fibrillation. For a condition that, in its mildest form, may never have caused a single symptom, these risks deserve a serious, personalized conversation. A recent review published in a top endocrinology journal concluded that the available evidence does not support routine thyroid screening in adults over 70 who have no clinical signs pointing to a thyroid disorder. The treatment risk, for many, simply outweighs the benefit. What to discuss with your doctor. If you've been receiving routine TSH panels, ask directly. Is there a specific concern driving this, or is it automatic? If levels come back mildly abnormal, ask what the realistic risk of treatment side effects is at your age versus the realistic benefit of treating a subclinical finding. Test number 4. Routine. Cardiac stress tests in low-risk, asymptomatic adults. This one surprises a lot of people because cardiac stress testing sounds like exactly the kind of proactive health management everyone should be doing after 70. For seniors who are experiencing symptoms, chest discomfort, unexplained shortness of breath during normal activity, new dizziness or palpitations, a stress test can be a genuinely life-saving diagnostic tool and the right call. The issue arises when these tests are ordered on a routine, scheduled basis for adults over 70 who have no cardiac symptoms and no new risk factors. That's where the research gets uncomfortable. A large-scale study involving thousands of low-risk adults found that routine cardiac stress testing in asymptomatic patients did not reduce the rate of heart attacks, hospitalizations, or cardiovascular deaths compared to patients who did not undergo routine testing. The test was not saving lives, but it was generating follow-up interventions. Because here's the clinical reality. Stress tests carry a false positive rate. They sometimes flag abnormalities that don't reflect actual heart disease. In older adults, that false positive rate is higher than in younger patients. due to age-related changes in cardiac anatomy and electrical conduction. Each false positive sends a senior down a diagnostic pathway that can include additional imaging and, in many cases, invasive cardiac catheterization. We want to introduce you to Walter. Walter is 74 years old, a retired electrician from Ohio. He played golf twice a week, walked his neighborhood every morning, and had no cardiac symptoms of any kind. But routine stress testing at 72 returned an abnormal reading. Walter was scared. When 2 follow-up procedures later, including an invasive cardiac catheterization, the cardiologist confirmed that Walter's heart was structurally normal. The abnormal reading had been a false positive. Walter spent 3 weeks recovering from a catheterization he didn't need. A minor complication at the insertion site left him unable to golf for nearly 2 months. "They told me everything was fine," he said to his daughter. "But fine didn't feel like what I went through to get there." A review of cardiac catheterizations performed after abnormal stress test results in adults over 70 found that in a significant portion of cases, some analyses placing it above 40%, no obstructive coronary artery disease was found at all. For what to discuss with your doctor, ask clearly whether this stress test is being ordered because of specific symptoms or risk changes, or because it's on a routine schedule. If it comes back with an abnormal result, ask your doctor to walk you through the full cascade of follow-up procedures, their risks, and whether watchful waiting might be an appropriate alternative. Of course, everyone's health situation is different, so always discuss any changes with your healthcare provider before modifying your screening plan in any way. If this information is new to you, that's precisely the gap these videos are built to close. If you haven't subscribed to Senior Health Decoded yet, now is the time. Click that button, and you'll get science-backed health content every week built specifically for adults over 60. The kind of information you deserve to walk into your doctor's office already knowing. Hit subscribe, and let's keep going, because the top 3 on this list are where it really matters. Test number 3, routine. Mammography in women after age 74. Mammography is one of the most emotionally charged conversations in women's health. For decades, the message has been consistent and clear. Get your annual mammogram. It saves lives. And for women between the ages of 50 and 74, that message is backed by solid, hard-won evidence. Regular mammography in that window is associated with real, meaningful reductions in breast cancer mortality. This is not in question. But after 74, and this is where many women are simply not being given the full picture, the medical evidence becomes significantly more complicated. Several major reviews have found that the absolute benefit of routine screening mammography continues to decline with age, while 2 specific risks increase considerably. The first is overdiagnosis. A large-scale analysis published in a leading oncology journal found that in women over 75, a meaningful proportion of screen-detected breast cancers were slow-growing tumors that would never have caused symptoms or shortened the woman's life during her natural lifespan. The cancer was real, but it was never going to harm her. And yet, once detected, those cancers were treated. Surgery, radiation, in some cases, chemotherapy. Real harm caused by treatment of a cancer that posed no real threat. The second issue is cumulative false positives. Research consistently shows that the longer a woman has been getting mammograms, the higher her cumulative probability of receiving a false positive result. A false positive means a callback, additional imaging, and frequently a needle biopsy, procedures that carry physical discomfort, potential complications, and weeks of psychological distress. A recent review published in a top breast cancer journal concluded that for women over 75 in good overall health with no personal or family history, that elevates their individual risk. The decision to continue annual routine mammography should be a deeply individualized conversation with their physician, not an automatic entry on a scheduling calendar. Meet Eleanor. Eleanor is 77, a retired school librarian from Vermont who had never missed a mammogram in her adult life. At 76, an annual scan triggered a callback. 6 weeks of follow-up imaging and a core needle biopsy later, it was confirmed as benign calcifications, a completely harmless finding. "I spent 6 weeks convinced I had cancer," Eleanor said. "The biopsy was painful. I didn't sleep properly for a month. And then they said everything was fine, and I was supposed to just go home." Eleanor's experience is exactly what researchers describe when they document the psychological and physical harm that can follow a screening-related false positive. The test was routine. The suffering was not. What to discuss with your doctor? Ask whether, given your specific age, health history, and family risk profile, annual mammography is still the right tool for you. Ask what your personal risk of overdiagnosis looks like. Ask whether the frequency needs adjusting, because this is a decision, not a default. Test number 2, PSA, screening for prostate cancer in men over 75. For men, the PSA test, prostate-specific antigen, has been a cornerstone of the annual wellness visit for decades. The idea makes intuitive sense. Measure this protein, catch prostate cancer early, save lives. And for men in their 50s and 60s, particularly those with elevated family risk, that logic holds up under scrutiny. But for men over 75, the evidence has shifted so dramatically that one of the most respected independent medical panels in the country has changed its guidance, and millions of men are still not being told. Here's why PSA testing after 75 deserves serious reconsideration. The PSA test does not diagnose prostate cancer. It measures a protein that can be elevated by a benign enlarged prostate, by a urinary tract infection, by recent physical activity, or by prostate cancer. It is a trigger for further investigation, and that further investigation is where older men face real, documented harm. A large-scale review published in a leading urology journal followed thousands of men over 70 who received PSA-triggered biopsies. The pattern that emerged was striking. The vast majority of prostate cancers detected in men over 75 were low-grade, slow-growing tumors. Cancers that would never have shortened these men's lives. Left undetected, most of these men would have died of something else entirely. Heart disease, another illness, natural causes, long before their prostate cancer caused any symptoms. But once detected, the psychological pressure to treat a cancer diagnosis is enormous. And treatment of prostate cancer at this age, whether surgery, radiation, or hormone therapy, carries serious, life-altering side effects: urinary incontinence, sexual dysfunction, significant fatigue, and cardiovascular complications. The U.S. Preventive Services Task Force, an independent panel of medical experts that evaluates screening guidelines, has formally concluded that the decision to screen men aged 70 and older for prostate cancer with PSA should be an individualized one, made with full awareness of the significant potential for harm. Meet Robert. Robert is 78, a retired high school football coach from Texas. At 76, a routine PSA came back slightly elevated. A biopsy followed. A low-grade prostate cancer was detected. Despite his urologist's reassurance that watchful waiting was a perfectly reasonable path, Robert pressed for treatment. "I couldn't sit there knowing I had cancer in my body and do nothing," he said. He completed a course of radiation therapy. The cancer responded. But Robert developed persistent urinary urgency that affects his daily life. And, as he put it quietly, "Things between my wife and me haven't been the same since." His oncologist told him afterward that statistically, this cancer was unlikely to have affected the length or quality of Robert's life without treatment. He told me I probably would have been fine, Robert said. That was a hard thing to hear after everything I went through. What to discuss with your doctor. Ask directly whether routine PSA testing is still recommended for your age and overall health status. If a test comes back elevated, ask your doctor to walk you through the full statistical picture, not just what could go wrong, but what would realistically happen if the cancer were monitored rather than treated immediately. Test number 1, routine colonoscopy after age 75. And here it is, the number 1 test on our list, the one we promised at the start. Routine colonoscopy. For adults between the ages of 45 and 75, colorectal cancer screening is one of the most evidence-supported preventive measures in all of medicine. It finds and removes precancerous polyps before they become cancer. It saves lives, and this is absolutely not in question. But after 75, and particularly after 80, the risk-benefit calculation changes so dramatically that the medical evidence around it is some of the most compelling research in senior healthcare today. A real, verifiable study published in JAMA Internal Medicine analyzed data from over 1 million Medicare patients and found that among adults over 75, colonoscopy complication rates were significantly elevated, while the probability of finding actionable cancer that would have affected the patient's lifespan was substantially reduced. The conclusion was direct. For most adults past 75, the risk-benefit balance of routine colonoscopy has fundamentally shifted. Why do complications increase so sharply with age? The reasons are multiple and significant. First, the bowel preparation. Before a colonoscopy, the patient must completely empty the colon using powerful laxatives over the course of 24 hours. This preparation can cause severe dehydration and serious electrolyte imbalances, and in older adults whose kidney function, cardiovascular regulation, and hydration tolerance are naturally reduced. This prep alone can trigger dangerous consequences: disrupted heart rhythm, blood pressure instability, and acute kidney stress. For seniors managing hypertension, heart conditions, or any degree of kidney impairment, this is not a minor inconvenience. It is a genuine medical risk. Second, the procedure itself. Colonoscopy perforation risk and bleeding complication risk both increase with age. Anesthesia and sedation carry greater risk after 75. Recovery time is longer. And unlike a 55-year-old who might experience a complication and recover within days, an older adult who experiences even a minor procedural complication can face weeks of serious health consequences. Third, and this is the factor that changes everything, there is the time horizon. A large-scale review involving thousands of seniors found that for adults over 75 who have had normal or low-risk colonoscopies in the past, the probability of developing a new colorectal cancer that would actually affect their health within their remaining natural lifespan is low. Meanwhile, the probability of experiencing a procedure-related complication is not. The U.S. Preventive Services Task Force, the same independent expert panel cited earlier, currently recommends that adults and their physicians discuss stopping routine colonoscopy at age 75, and states explicitly that there is no evidence supporting screening after age 85. This is not a fringe recommendation. This is the official guidance from one of the most conservative, evidence-based bodies in American medicine. Albeit critically, this does not mean abandoning colorectal cancer monitoring altogether. For adults over 75 who still want ongoing surveillance, stool-based testing offers a powerful, evidence-supported alternative with none of the procedural risk. The FIT test, fecal immunochemical test, and the Cologuard multi-target stool DNA test are both covered by Medicare. Both demonstrate strong sensitivity for detecting significant polyps and cancers, and both can be completed entirely at home, with results mailed to a laboratory. No bowel prep, no sedation, no recovery time, no procedure risk. We want to tell you about Grace. Grace is 79, a retired florist from Oregon. She had been scheduling her routine colonoscopy every 5 years for as long as she could remember. At 78, she was scheduled again. Her daughter, a registered nurse, now had been reading the updated clinical guidance and encouraged Grace to have a real, informed conversation with her gastroenterologist before simply going through with it. "I never once thought to question it," Grace said. "I just did what they told me." Her gastroenterologist reviewed her full history. Grace had never had a polyp in any prior colonoscopy across 25 years of screening, and agreed that at 79, for Grace specifically, the balance had shifted. The procedure risk exceeded the likely benefit. They transitioned her to annual Cologuard testing instead. "I can't tell you what a relief that was," Grace told her daughter afterward. "I'd been dreading the prep every single time. Now I just put something in the mail." Grace's experience captures exactly what the research calls for. Not a blanket rule, but an individualized, fully informed conversation where the patient's history, health status, and personal values all shape the decision. What to discuss with your doctor. Ask your doctor directly. "Given my age, my previous colonoscopy results, and my current health conditions, is a repeat colonoscopy still the right tool for me? What are the specific complication risks of the prep and the procedure at my age?" And ask whether a stool-based alternative, FIT or Cologuard, would be medically appropriate for your situation. Action steps. Here's exactly what to do with everything you've just learned. 5 steps. Start this week. Step 1. Before your next annual physical, write down every routine test or screening currently on your schedule. This includes colonoscopy, mammography, PSA testing, cardiac stress testing, thyroid panels, and any imaging. So that list becomes the foundation for a real conversation, not a passive schedule you follow without question. Step 2. For every test on that list, ask your doctor one specific question. "Given my age, my individual health history, and the current evidence, does the benefit of this test still outweigh the risk for me personally?" Push for a specific, personalized answer, not a reflexive, "it's just routine." Step 3. If you're over 75 and currently scheduled for a routine colonoscopy, ask your doctor specifically about stool-based alternatives. Both the FIT test and Cologuard are Medicare covered. If your doctor isn't raising them as an option, ask why. And ask whether your prior colonoscopy history supports a transition. Step 4. Request a formal screening review at your next visit. Many adults over 70 are still on screening schedules that were built when they were 50 or 60 and have never been revisited in light of their age, current health conditions, or the updated evidence. You are entitled to ask for that review. It is your health care. Step 5. Bring someone with you to your next appointment. A family member, a close friend, an advocate. Someone who can help make sure questions get asked, answers get written down, and decisions get made with complete information rather than habit. Now we want to hear from you. Has a doctor ever recommended a test that you later found out might not have been necessary? Or have you had a conversation that changed your screening plan? And are glad you did? Tell us your story in the comments. Your experience may be exactly what another viewer needs to hear today. If this video gave you something valuable, please share it with someone over 70 in your life. One conversation could make a real difference.